Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Picture this, right? It's 2 a.m. You're a doctor or maybe a surgeon on a brutally busy on-call shift, and your pager goes off. The message: a massive, high-volume, lower GI bleed down in the ER.
Yeah, that's the one that definitely gets the adrenaline going, for sure.
Oh, absolutely. Because you know right then that a dozen critical decisions, everything from fluid resuscitation to pulling the trigger on surgical escalation, they all need to be made in the next 10 minutes.
You really don't have time to go flipping through textbooks at 2 a.m.
Exactly. So we are bypassing the basics today. Our mission for this deep dive is specifically for you, the clinicians on the front lines. We're unpacking the latest, most critical guidelines from the BSG, that's the British Society of Gastroenterology, and the ESGE, the European Society of Gastrointestinal Endoscopy.
Right, which are pretty much the gold standards right now.
They are. And just before we get into the weeds, I do have to say this. Please note, this content is for reference only. Always ensure you follow your local guidelines in clinical practice.
Definitely. Local protocols always win out.
Always. So let's set the stage here. What are we actually dealing with when we talk about a lower GI bleed?
Well, anatomically speaking, we define an acute lower GI bleed, or LGIB, as bleeding that occurs distal to the ligament of Treitz.
Okay, so basically everything past the duodenal flexure.
Exactly. The rest of the small bowel, the entire colon, and the rectum. And clinically, it typically presents as hematochezia, bright red blood per rectum, often with these large clots or maroon stool.
And the numbers on this are wild, Rick, because, overall mortality sits around, 2 to 4%?
Yeah, about 2 to 4% generally. But the extremes, the ones that actually keep you up at night, those are the catastrophic bleeds with hemodynamic collapse. In those cases, the mortality rate easily exceeds 20%.
Wow, 1 in 5. That is massive. And when we're looking for a culprit, diverticular disease is still the most frequent one, right?
By far, yeah.
Yeah.
But your radar also has to catch things like angiodysplasia, colorectal neoplasia, ischemic colitis.
And even just severe anorectal conditions, right?
Exactly. But, before anyone starts hunting for the specific lesion, you have to arrest the patient's physiological decline. You can't find the bleed if the patient is crashing.
Right. Keep the patient alive first. So the first 15 minutes, we're doing the standard ABCDE approach.
Yeah, secure dual, large bore IV access. Get fluids going immediately and send off urgent bloods. Full blood count, UNEs, LFTs, coagulation profiles, and crucially, a cross-match.
Right. And I noticed the 2019 BSG guideline places a huge emphasis on early hemodynamic assessment, but they really move away from just relying on a standalone blood pressure reading. They seem heavily focused on the shock index.
They are, and for good reason. It's such a better metric.
Which is just the heart rate divided by the systolic blood pressure, right? I always think of it as a clinical check engine light for the patient.
That's a great way to put it, actually, because, a patient's systolic BP might still be clinging to normal because of massive systemic vasoconstriction.
Right. The sympathetic drive is just working in overdrive to keep them alive.
Exactly. But if their heart rate is, say, 120 and their systolic is 110, well, that index is over 1. They're already in a state of covert shock.
So anything over 1 means imminent danger.
Yeah. If the index is greater than 1 after your initial fluid challenge, they're officially categorized as unstable. They need rapid escalation, critical care involvement, and urgent imaging.
But here's where I want to push back a bit, or at least play devil's advocate. If a patient is passing bright red blood, why do the guidelines scream about checking the upper GI tract? It feels counterintuitive on a chaotic ward.
I know, it really does. You see bright red blood, you assume a distal source. But you have to remember that blood is a highly potent cathartic agent.
Wait, meaning it basically acts as a laxative?
Exactly. A profound high-volume upper GI bleed like a spurting duodenal ulcer or ruptured esophageal varix can stimulate this massive hyperactive peristalsis. It moves through the entire digestive tract so fast that the hemoglobin just doesn't have time to be degraded by gastric acid.
Oh, right. Because normally that degradation is what turns it into melena, that black turry stool.
Precisely. So instead, it emerges looking exactly like a primary colonic bleed. We call this the upper GI masquerade.
The masquerade, right. So how do you actually spot it then, aside from the shock index?
The urea levels. If you have a patient with hematochezia and a shock index over 1, or they have a disproportionately elevated blood urea nitrogen level because digestive blood proteins get absorbed in the small intestine, That is a massive red flag.
Okay. So the guidelines, both BSG and ESGE, recommend an urgent OGD and upper endoscopy to rule that out.
They strongly recommend it,
Yeah.
especially if a subsequent CT angiography doesn't find a lower source. You really don't want to miss a massive upper bleed.
And speaking of not missing things, the physical exam protocols are super strict about doing a digital rectal exam, a DRE.
Oh, it is absolutely mandatory.
Because I guess in a chaotic ER, it's probably really easy to conflate a massive proximal bleed with like a really brisk distal anorectal bleed.
Oh, it happens all the time. Overlooking a bleeding arterial hemorrhoid just because you rush the patient to the CT scanner. I mean, that is a critical error. The DRE is a baseline requirement.
Right, because you don't want to activate a massive hemorrhage protocol for something that just needs local packing or a quick suture.
Exactly. You have to rule out the benign stuff right at the door.
Okay, so the immediate crisis is managed. You've done the DRE, you've stabilized the hemodynamics. Now we hit this critical triage phase. Who stays in the hospital and who gets to go home?
Right. And you basically have to divide your stable patients into minor and major bleeds. Minor bleeds are self-limiting, hemodynamically stable, no significant drop in hemoglobin, and no major comorbidities.
And major bleeds are basically everyone else who doesn't meet those strict criteria, but they're still stable enough that they don't need the ICU.
Exactly. And this is where the guidelines bring in the Oakland score. It's the key tool to identify which patients are safe for discharge and ambulatory investigation.
Okay, break the Oakland score down for us. What goes into it?
It integrates a bunch of predictive variables: age, gender, previous admissions for LGIB, DRE findings, heart rate, systolic BP, and hemoglobin concentration.
So it's basically quantifying the risk of bad things happening, like rebleeding, needing a transfusion, or dying in the hospital.
Right, and the validated threshold for a safe discharge is an Oakland score of 8 or less, assuming there are no other adverse features.
But I mean, let's be real here. It must be absolutely terrifying for a doctor to send a patient home who was just passing visible blood a few hours ago. Like, does a score of 8 really offer some kind of magical protection?
Well, no, a score never overrides clinical judgment. The BSG guideline is very explicit about this. It's not an absolute mandate.
So it's more about data-driven confidence.
Exactly. Statistically, an algorithmic approach is safer than relying on gut feeling. But you have to pair that score of 8 with really strict safety netting.
Meaning you make sure they have a safe home environment, they're cognitively intact, and they know exactly when to rush back if they start bleeding again.
Yes. If you do that, it frees up critical hospital beds for the truly high-risk patients, while ensuring the minor bleeds get a swift outpatient colonoscopy.
That makes total sense. Okay, so for the patients you do admit, managing their blood levels and untangling their home medications becomes the next massive hurdle.
Oh, it's a huge challenge. Let's start with the blood products. Both the ESGE and BSG strongly advocate for a restrictive transfusion strategy.
Right. So for stable patients without cardiovascular disease, they say only transfuse when hemoglobin falls to 7 grams per deciliter or below. And you're only aiming for 7 to 9. Why so low?
Well, it comes down to physiology. When a blood vessel ulcerates and bleeds, the body forms a fragile fibrin plug to stop it.
Right. The natural clot.
Yeah. But if you aggressively transfuse and rapidly increase the intravascular volume, you spike the hydrostatic pressure, and you run the risk of literally blowing that precarious clot right off the vessel wall.
Oh, wow. Okay, so it's basically a plumbing issue. Too much pressure in the pipes, and you blast the patch right off.
That's exactly it. And observational data backs this up. Liberal transfusion strategies actually lead to higher rates of rebleeding and mortality. You just want enough oxygen-carrying capacity to perfuse the vital organs. No more.
Unless they have cardiac issues, right? Because the guidelines shift the threshold for patients with ischemic heart disease.
Right, because a compromised myocardium just cannot tolerate profound anemia. For those patients, you transfuse at 8 grams per deciliter, aiming for 10 or higher.
Okay, so managing the blood is one thing, but managing their antithrombotic medications, I always compare that to diffusing a bomb. You know, you cut the wrong wire and they clot, but you leave it alone and they bleed out.
That is the perfect analogy. The clinical tension is immense. You're balancing the risk of fatal exsanguination against the risk of a massive stroke or an MI.
Let's run through the common meds. Warfarin. What do we do?
If it's an unstable hemorrhage, interrupt it immediately. You reverse it using 4-factor prothrombin complex concentrate PCC alongside IV vitamin K.
Because PCC rapidly replenishes those vitamin K-dependent clotting factors, right? 2, 7, 9, and 10.
Exactly. Now, for DOACs, the direct oral anticoagulants, you also interrupt them immediately. In life-threatening scenarios, you bring out the specific reversal agents.
Like adarisuzumab for dabigatran.
Yes. It binds to dabigatran with an affinity way higher than thrombin, neutralizing it instantly. And for factor exhibitors like rivaroxaban, you consider anandexanet alpha.
Right, the decoy receptor. But what about antiplatelets? Aspirin has to be a total nightmare to figure out.
It depends entirely on why they are taking it. If it's for primary prevention, meaning they've never actually had a cardiovascular event, you stop it permanently.
Because the immediate risk of bleeding to death vastly outweighs some theoretical heart benefit down the road.
Right, but secondary prevention is the dangerous one. If they have established cardiovascular disease, aspirin generally has to be continued, or at least restarted the moment hemostasis is achieved.
And what about dual antiplatelet therapy, DAPT, like for a patient with a recent coronary stent?
You never routinely stop DAPT for a coronary stent. The mortality of an acute ST elevation MI from a clotted stent is catastrophic. It is usually much higher than a controlled GI bleed.
Right, so if you absolutely must withhold one agent to stop the bleeding, what do?
You keep the aspirin going, and you consult cardiology immediately about the P2Y12 inhibitor. Never just blindly stop both.
Got it. Okay, so the patient is stable, the blood is managed, the bomb is diffused with the meds. Now, how do you actually find and plug the hole? We have two main diagnostic pathways here, colonoscopy and CT angiography.
Let's start with the stable major bleeds. For those, inpatient colonoscopy is your primary diagnostic and therapeutic tool. The DSG recommends doing it within 24 hours.
But there is a massive catch there, isn't there? The bowel prep.
Oh, yes. It is a non-negotiable prerequisite. You have to have adequate bowel preparation.
Because I imagine attempting a scope in an unprepared colon filled with blood and stool is just completely futile.
It's worse than futile. You can't see the mucosa, so you definitely can't see the bleeding source. The therapeutic yield is dismally low, and you actually increase the risk of perforation.
So once they are properly prepped and you get in there, what can the endoscopist actually do?
If they find high-risk stigmata-like active spurting, a visible vessel or an adherent clot, they can treat it right then and there. Hemoclips, thermal coagulation, injecting dilute epinephrine.
But that entire pathway goes completely out the window if the patient is unstable, right? I mean, you can't exactly force 4 liters of bowel prep into a patient in hypovolemic shock.
No, absolutely not. If the shock index is over 1 or they have massive ongoing hematochezia, colonoscopy is useless. It just delays definitive care.
So we go straight to CDT, angiography, CTA for the unstable bleeds.
Yes, CTA is the absolute gold standard here. It's rapid, it's non-invasive, and it is incredibly sensitive. It can pick up active extravasation at rates as low as 0.3 milliliters per minute.
Wow. So you can literally see the contrast dye spilling out of the vascular tree into the bowel lumen on the scan.
Exactly. And once you localize that extravasation, you rush them straight to interventional radiology.
IR is amazing for this. The radiologist snakes a catheter into the mesenteric arteries, finds the exact vessel, and just coils it, right?
Yeah, super selective embolization. They use microcoils or gel foam to occlude that specific bleeding vessel, all while preserving the blood supply to the rest of the bowel.
It's incredible. But what happens if the endoscopist can't see the bleed and the CTA doesn't show any active extravasation, but the patient is still unstable and bleeding out? We're entering the final, most drastic phase of the algorithm, right?
Unfortunately, yes. We're talking about surgery.
Yeah.
But modern guidelines view emergency laparotomy strictly as a last stand, a measure of absolute last resort.
And that makes sense. The physiological toll of cutting open an older, hypovolemic, coagulopathic patient is massive.
It is. You only call the surgeons when optimal, less invasive attempts have completely failed, or if IR and endoscopy are just geographically unavailable in the life-threatening time frame.
And when they do operate, you want to avoid a blind subtotal colectomy at all costs, right? I always think of that as tearing down the entire house just because you couldn't find the leaky pipe in the bathroom.
That is exactly what it's like. A blind colectomy carries prohibitive morbidity and mortality rates. This is why preoperative localization is so critical.
So using the CTA or angiography or even intraoperative endoscopy to find the exact spot.
Yes, because if you know exactly where the bleed is, you can perform a targeted segmental resection. Just remove the compromised piece of bowel. It massively improves their chances of surviving the operation.
Okay, let's distill all of this into a rapid-fire mental model for the day-to-day practice. Walk us through the sequence.
All right. Step 1, resuscitate and assess stability, calculating the shock index. Step 2, triage. Classify minor versus major bleeds using an Oakland score of 8 or less for safe discharge. Step 3, for stable major bleeds, admit and do a fully prepped colonoscopy within 24 hours. Step 4, for unstable bleeds, bypass the scope, get a CTA, and embolize an IR. And finally, step 5, reserve targeted surgery as your ultimate, final safety net.
It is a brilliant, evidence-based pipeline for what is otherwise a wildly chaotic clinical presentation. But it leaves me with one final provocative thought for you to mull over.
Yeah, what's that?
We are watching interventional radiology and advanced endoscopic techniques evolve at literal lightning speed. Microcatheters are getting smaller, embolic agents are more precise, over-the-scope clips offer massive tissue apposition. We even have hemostatic powders now.
That's true. The tech is unbelievable.
Right. So given this trajectory, are we rapidly approaching a future where the emergency colectomy for a lower GI bleed becomes completely obsolete? Like just a purely historical procedure that we talk about in M&M conferences, but nobody actually scrubs in for it at 3 a.m. anymore?
Well, it's a fascinating thought. We're certainly doing far fewer of them today than we did 10 years ago.
Exactly. Definitely something to keep an eye on. All right, if you like this content, then do not forget to share with at least one of your colleagues or friends and spread the word. Also, check out our YouTube and other social media pages, and definitely do check our previous season and episodes, which are packed with some very relevant topics. Until next time, trust the algorithms, check that shock index, and we'll catch you on the next deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.